Welcome everyone to today's webinar, Healthcare Waste, how to identify inefficiencies and navigate a system that's not ready to change. On behalf of Beckers Healthcare, thank you for joining us today. Before we begin, I'm going to walk us through some quick housekeeping instructions. So first, we'll begin today's webinar with a discussion, and we'll have time at the end of the hour for a Q&A session with our audience. Audience members, you can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. Today's session is also being recorded and will be available after the event. To access that, you can use the same link used to log into today's session. Lastly, if at any time you don't see your screen moving or have trouble with the audio, you can try refreshing your browser page, or you can also submit any technical questions into the Q&A box on your screen. We are here to help. With that, we have a great panel set up today with two healthcare veterans that are here to talk about their experience with value-based care and their keys to success as they navigated a system that just was not ready to change. So to get started, I'd love for them both to introduce themselves. So I will pass it over to Blain Claypool to get us started.
Thank you. I'm Blain Claypool. I'm Chief Operating Officer of HNI Healthcare. Prior to joining HNI, I was a hospital executive for 30 years, greater part of the last decade plus as a CEO. Multiple type facilities, level 1 trauma centers, community medical centers, and then also regional responsibility for multiple campuses.
Hello, everybody. I'm Reuben Tovar. I'm a hospitalist. This month, I am celebrating my 25th year as a hospital medicine physician. For the last 10 years, though, I've had the privilege of being the Chief Medical Officer of HNI Healthcare.
Wonderful. Thank you, Blain. Thank you, Dr. Tovar, for being here. We're so excited. So let's kick things off by talking about value-based care. This term has become a buzzword recently that seems to be sprinkled into headlines and articles, but what does it really mean? Why is there such a push, and why aren't systems already practicing it?
Well, I'll start by saying what value-based care is in our minds. That is the process of continually improving healthcare while at the same time reducing the cost of care. The story actually starts well before, though, when the Institute of Medicine published in 1999 the quality chasm. And they gave physicians at that point 6 domains for us to improve care. And they were very reasonable things: safety, care was safe, effective, patient-centered, timely, efficient, and equitable. But with the rising cost of healthcare, essentially twice per capita in the United States than any other country in the world for the same outcomes, the definition of quality was altered and improved upon by the Institute of Healthcare Improvement, who said, yes, quality chasm, those 6 items are very important, but that's what happens when the patient comes to the hospital when they need a tune-up. What is also important is health of our population. Why did they have to come to the hospital? Are we doing their colonoscopies, their mammograms, their stress tests, their lipid management? So let's make our patients healthy so they don't need the hospital as much. And then lastly, and I think the biggest change, was that to the quality definition for a physician, they added cost of care. How much a physician utilized to take care of their patient then becomes an important indicator of their quality. You know, of course, cost of care has always been a financial indicator, an operational indicator for a hospital. But more recently, it's an indicator of quality for physicians and hospitals. And the only way really to improve cost of care is to coordinate care. Value-based care is predicated upon the ability to coordinate care. And I would say that physician groups and health systems have really struggled to manage through that because they lack real-time actionable data that is trusted by physicians, trusted by a healthcare that provides them a backbone, a digital backbone really, for the management of care throughout the continuum. And it's this lack of information and actionable data that led HNI Healthcare really to develop Vitals MD.
You know, I think Reuben hit on it. And, you know, even with the Institute of Medicine and the value-based healthcare and the value-based reimbursement that CMS pulled out based on those indicators, let's just be real. Hospitals have been on value-based healthcare since the implementation of DRGs in 1982. when we started being subcapitated at a hospital and DRGs basically started paying a flat rate, you had already crossed the chasm and we were there. Flash forward 40 years. Hospitals still struggle and scratch their heads today of how do you make money and how do you make an acceptable margin on a Medicare patient? Well, you won't unless you actually have actionable data in the hands of your physician, who is at the tip of the spear of driving the quality of care and who we want at the tip of the spear driving quality care. If you don't give them real-time data to make decisions, you're not going to solve that enigma. And you're not going to hit the basic metrics of geometric mean length of stay, let alone the real implications that you need to on quality, on discharge appropriateness into next site of care. It's akin to asking an NBA team, two NBA teams to play in the championship, but don't give them the scoreboard. Here you have phenomenal athletes, phenomenal physicians. They don't know the score. They don't know what's expected of them. And we had to change that.
You know, I would say that Blain's comment on real-time data is spot on. I know from the physician perspective, as I'm admitting a patient, I really have no idea how long the patient should be there. I have no idea about the severity or the risk. So what a physician needs really to self-manage is, as I'm documenting, I need to know what is my patient's severity, what is their risk, and what is their severity adjusted length of stay target. And when I know that information, well, then certainly I want to manage to it. All physicians want to compare well to their peers. And I think having the data in front of them immediately allows them to self-manage. I think physicians are notoriously difficult to manage. However, the best manager of the physician is actually the physician.
When they have that data. You know,
Reuben,
when they've got that data and they know where they're at and what the score is, when it comes down to it, you know, they know what is expected. And that's how they successfully underwrite the cost of care in a hospital, by accurately portraying, you know, the illness of the patient, the acuity of the patient, and understanding where they stand against the generalized norm of geometric mean length of stay.
Exactly. And has to be, that data has to be available when you're admitting the patient. You can't receive that data 3 months later in the C-suite talking about 3 months ago. The only way to affect today is to have data right now.
Absolutely. I mean, that's the other side with value-based healthcare and, you know, third parties that you deal with, or even waiting on information to come from CMMI. It's 30, 60, 90 days old, sometimes 180. You really can't solve problems there.
Wonderful. Data seems to be the key. You guys have really honed in on that. So with data being the key, what type of data is key to capture? And how do you use this data to drive those conversations with those key stakeholders?
Go ahead, Reuben. Go ahead, Joe.
Well, I think the most important aspect of any data set must be that it's trusted. The physicians trust it. The hospital trusts it because they vet it. And I think the only data really that a physician trusts is the data they entered. And so for most of my career, I would say I'd walk into a C-suite and I would receive my performance data. And I'd always ask, how was this data aggregated and attributed to me? And generally the presenter, usually a C-suite member, did not know how the data was aggregated and attributed. And that always put me off a little bit. And then I would ask, how old is the data? And they would tell me 3 to 6 months. So I think what ensues really is a polite, of course, but low yield conversation, versus if I walk into that same C-suite and I receive my quality data from an administrator and I ask, where did you get the data? If the answer is, well, you entered it, then I really trust that data more. And then when I ask, how old is this data? And if the answer is, well, last month, but we can do yesterday if you want, then what ensues is a high value, patient-centered, accountable conversation to physician performance. And when you do this, you change physician behavior, because at the end of the day, we succeed in value-based care because physicians are making value-based decisions, and they need information to be able to do that.
You've nailed it, Reuben. I can't tell you how many of conversations that I had similar to that in the CEO role with a physician, utilizing the only resource I had. And back in 2013, I encountered Vitals MD, and all of a sudden took my entire conversations from ones of legend and lore. Because let's be honest, that's the way hospitals run. They run on legend and lore. He said, she said, and where we're at, and we're grabbing pieces of data left and right that we've all got. I mean, hospitals are data rich and information poor. So as much as Reuben and I have talked about data, the key is capturing the data and converting it to actionable information. And that's those type discussions that Reuben alluded to, is when you've got real-time data that was entered by the physician that has real benchmarks, and we can look at 30, 60, 90 days out or yesterday. I've now moved from a completely subjective discussion to an objective discussion that yields a much higher value and allows us to address the quality issues that will improve the care for patients, getting them in and out of the hospital in a timely manner, but most importantly, fulfilling our home-to-home obligation. Because that's really what we're obligated to do under value-based care, is take that patient from their home status back to the home. Whether it is their actual household or they came from another assisted living facility, let's get that patient home to home safely and make sure they do not come back to the hospital as a readmission.
How our data, or how real-time data has really changed my behavior as a physician. I would say for the first decade of my career, I did not manage to severity adjusted length of stay targets. I didn't even know what the targets were. I had no idea of its relevance. And so my length of stay was typically 1.5 days over. I was the beneficiary of that, of course, because I was paid on a production system. The reality of my practice now is that because I know my targets from the time of admission, I generally do practice to severity adjusted length of stay, and I document in a manner that ensures that I can. The reality for the patient is that every day in the hospital is a bungee jump. Most of the time it goes just fine, but every once in a while it does not. And the problem with that is when it doesn't, it's catastrophic. There's a host of hospital acquired conditions that in reality don't happen if you're at home. So it is the safest and best place for the patient is to go home. And in a value-based world, I ensure that I coordinate care on that last day or the day before even. So I ensure that I'm not readmitting the patient with the same problems, 7 days later.
In the acute care setting, geometric mean length of stay is the target. People may compare themselves against hospitals of different bed size, of different services, level 1 trauma centers. Geometric mean length of stay is the great equalizer. And providing that information to the physician, who can then look and say, well, my patient's much sicker than that. Have you documented it appropriately then? Have you accurately captured and underwritten the risk associated with this patient and accurately provided the diagnoses that roll up into a DRG that show how long the patient should be at the hospital? But let's take value-based care a step further. If you're not tracking what happens to them post-discharge and you're just recklessly allowing this patient to go to the wind, you're going to end up with a higher readmission rate. You're going to end up with a higher overall cost. Whether it's a value-based program where you're responsible for a 90-day bundle, or whether you're part of an ACO or the new ACO REACH that's coming, we've got to look across the spectrum and again, go from that home to home and keeping the patient home and driving the results that will end up with a 30% lower readmission rate than the benchmark on Hospital Compare. It is real and it is attainable if you provide the information to your scientist, your physician, to make the right decision for the patient, keep them safe, and get them home.
Yeah, I'll add to that, Blain, in that, when we admit a patient, our admitting impressions are not always, after further study, the correct impression. And what's important for me as I manage to severity adjusted length of stay within a hospital is that if my initial diagnostic impressions, evolve over time because data has accrued and I can act on that data. And then my length of stay targets, my severity, my risk all change instantaneously so that I can manage to my new threshold for my sicker patient. And the reality of managing to either a time threshold or a financial threshold, the key factor is having a proper capture of risk and severity, because the waterfall of clinical information will follow that.
I think it also, you look at the impact in value-based arrangements where HCC scores and RAF scores are impacted. Providers have probably never heard that term. And what does that mean? And, Reuben, you can give great examples on how that works and understanding the dynamic of capturing those risk scores on our patients.
No, absolutely. In particular for managed populations, if a patient comes to me with pneumonia and one of their baseline HCCs is not HCC 18, which is the most common one, diabetes, and they have new onset diabetes when they see me, if I capture that MCC, or HCC, I have partnered with my managed care physician in a way that improves the threshold for the primary care physician. And in that way, I, as a hospitalist, am the extension of the primary care physician in the hospital. And I think in a managed environment, the two physicians that truly matter are the primary care physician, who captures MCCs and makes continuity of care decisions, and the hospitalist in the hospital that adds a new diagnosis and coordinates care as they return to the primary care physician.
And coordinating the transition of care, being able to communicate effectively during the hospital stay with the primary care provider, giving them full visibility into what's happening with their patients at any time, and the ability to communicate effectively with that hospitalist electronically in a secure environment also further enhances the benefit and then eases that transition of care. I'll keep going back to that next side of care, and next side of care matters. Next side of care matters where patients go, because you can just look at the data if you have it. When you take the data and see what happens to patients when they go to home with home health, a skilled facility, or any other setting, you've got the ability to then sit down again with your providers and your physicians and go, look, the most effective place for patients to go upon discharge is X based on their diagnosis. We know that information, and we can provide that information to our providers to make sure our patients are discharged safely and drive a much lower readmission rate as a result.
Yeah, and the data we accumulate allows us to recognize where, first of all, our patients are coming from. The only patients we truly can send home are patients from home. So we capture that data. And I know I have a patient who was ambulatory, living independently at home at the time of admission. So what is important for me to do then is to maintain adequately my patient's nutrition, to have my patient out of bed and participating in their activities of daily living. Because when I don't do that, then I have not acted in my patient's best interest. We've all had the ambulatory 80-year-old gentleman who comes in with pneumonia. And 4 days later, I tell him, sir, Mr. Jones, you're ready to go home. Your white blood cell count is normal. You're done with your antibiotics. You should do well. And he looks at me and says, hey, doc, I can't walk anymore. So now I have to send this person to a skilled nursing facility. It's going to take this gentleman 12 months, which is a high percentage of his remaining life in all likelihood, to return to prior level of function. During that time, he will experience high cost of care, more depression, and more anxiety than he would if he was at home.
Yeah, that's the information that we have, and that's in providing that information to our providers, allow them to, again, make the right decision for the patient, give them the quality of care that they deserve and that they expect.
So well put. And everything you guys are saying is making a lot of sense in theory, but we know that change can be hard for many, especially for physicians. So how have you worked with clinical teams to change their mindset from fee-for-service to value-based care?
I think it's just like anyone else. Once you provide somebody with information that they haven't had before, they take to it. And as Reuben so eloquently put earlier, the best manager of a physician is the physician. Physicians by nature are competitive. And again, they are scientists. So you put that in front of them and they're going to start correcting their course. And ultimately, their commitment is to the highest level of care for a patient. So we've seen where we implement our services and where we come in and bring this data and start collecting this data, we've seen dramatic change in 30 days or less. As we give a tool to someone who has had none. I went back to the NBA basketball game without a scoreboard. How do you know what's expected of you? You put a scoreboard up, an NBA player is going to rise to the occasion. You give a physician their score, they will rise to the occasion and they will do what it takes to improve the quality of care in an expeditious manner.
I think that's key. So typically when a hospitalist gets data, it's aggregate data. It's how does the team impact the hospital? I will tell you what the physician is worried about is their contribution to that aggregate. And so when you have reliable patient-centered, physician-entered, hospital-validated, attributable data to the physician, then the physician's behavior changes. They start managing to length of stay because they can compare themselves to the rest of the group, and more than half the group already is. And I'm not. Well, I'm going to correct myself. That physician will then know how many of my patients from home am I sending home. If the group's at 85% and I'm at only 50%, I'm going to correct. If the group is at 15 or 10% readmission rate, but I'm at 20, well, I'm going to correct. And this is the transition from a volume-based practice to a quality-based practice. And the physician who has become accustomed to seeing a high volume of patients to make the extra dollar, for those physicians, it's not don't make that extra dollar. Instead of seeing 25 to 30 patients, let's have you see 18 patients, and we'll incentivize you for the remainder of that money, not to work on volume, but to work on discharge in a timely fashion, discharge in the morning, readmission, next site of care. So at the end of the day, the physician has the opportunity not to work harder, which I don't think many of us can do, but to work smarter, which is, I think, something we would all like, but that requires actionable real-time data.
I think that's key, Reuben. You've got to realize that for decades, easily since 1982, that there has been a complete misalignment of incentives between a hospital and a provider. The hospitals are capitated, essentially. You're subcapped on your DRG, and as more and more contracts moved out of a per diem into a DRG-based reimbursement, hospitals are capitated. Providers still get $80 per click per day. So, who's going to make those decisions? Our incentives aren't aligned. When you move into a value-based setting and providers are paid, a fair base, but incentivized to hit key quality metrics with good data to make those targets, now all of a sudden we've aligned the incentives with the hospital. That both individuals, the hospital and the providers, are making the right decisions for the patient, and we're not making decisions based on, I get to clip another coupon today. And if I keep a patient another day, I get to clip another coupon. And if I keep them another day, I get to clip a coupon. It's let's get the patient underwritten appropriately by accurately capturing their diagnosis. Let's keep them in the hospital what is appropriate and get them home safely versus give me another $60.
Yeah, in my own life, what you explained, Blain, is exactly what's happened to me. I would say when I was a young hospitalist in the first few years of my life, I routinely intended really to have the patient, a certain number of days. And I thought I was doing the right thing. I thought, okay, I'm gonna have my patient here in the hospital. That's better for them. That's safer. Oh, and by the way, I benefit. The problem with that is that, as you mentioned, the hospitals are capitated. So for every extra $80 I was getting, the hospital was losing $600. And so the ways we make money were completely opposite. And who's the loser, of course, in the middle? The patient. Mm-hmm. But in a value-based approach, the physician and the hospital win in the same way. And then the big winner is the patient who gets to go home in 3 days instead of 5 days. You know, if you're a patient coming to the hospital and you have pneumonia, do you really want to be there 5 days or 3 days? You want to go home as quickly as possible. 3 days is the winner. So please send me home. Let's get me out of bed. Give me proper nutrition. I'll see you only for 3 days, and I'll see my primary care physician. I will do my convalescence and recovery in my own bed, in my own home.
And I think even more important than that, Reuben, is, you know, when a patient does need to go to a post-acute setting, you've got to take that information that you have from the acute, transfer it into the post-acute, and still capture it and give the provider in the post-acute that exact same information. So they're making the decision on the patient, excuse me, to keep them in the post-acute setting for the right amount of time. It's not an automatic 31-day ticket. You know, no, that's what is the intentionality and how do we get the patient home safely?
That's the beauty of the data that we use to manage our practices. The tool creates a digital backbone that allows the operational leverage to manage the patient throughout the continuum. If the patient has proper risk stratification when they reach the skilled nursing facilities, our teams can start seeing the patient the right number of times over the right duration and do two things: hopefully truncate skilled nursing facility length of stay, and then reduce readmission rate from the skilled nursing facility, which is a high readmission location.
Yeah, and it also gives visibility and again, taking data and converting it into actionable information, visibility into where are your higher readmission facilities, you know, and why. And, you know, an important conversation for then our providers to have with that facility about your readmission rates are a multiple of your peers. And how can we change that? And what do we do? And let's embed ourselves and educate your nursing staff. Let's educate your individuals. Let's talk about what we can do to improve your overall performance as a post-acute setting at the same time.
Yeah, you know, I think that's mission critical. I think what happens to most patients when they're going to need a skilled nursing facility is a case manager or hospital personnel will come in with a list. And it's just a list of all the places that they can go to around the hospital. And the most obvious question is, which one's closest to my house? And that invariably is the one the patient will choose because that's where the patient believes their family's going to visit. And that's where they're more comfortable, near their house. The problem with that is that is an uninformed choice. They're just going because of geography. If, however, a physician or case manager comes not with a location grid or a capability grid, but a performance grid, and we can tell that same patient, ma'am, if you go to the place right by your house, because you have this diagnosis, you will be readmitted 25% of the time in the first 30 days. Versus if you go to the place 10 minutes down the road, you're going to be readmitted for that diagnosis 10% of the time. 100% of the patients, when given informed choice, will choose the better performing place. So it's much more patient-friendly to provide them performance data and not just a blind list. It's the preference of informed choice versus uninformed choice that really helps drive results like readmission.
We owe that to the patients. We should have that information at our hands and owe that to the patients so they understand where they're going to be receiving the care and what the norms are around it. You know, that's the beauty of value-based care. It's now taking us into these level of discussions with the accurate information to make the right decisions for the patients to get them the highest quality care. That's what it's supposed to drive. Quality actually costs less. I've watched it happen time and time again. If you do it right, it's going to cost less, and we can get ahead and bend the cost curve in healthcare in this country by getting behind the value-based care initiatives with the correct data and with the right information, coupled with exceptional providers that we have.
Well, you're right about quality being the least expensive form of care. What patient doesn't want to go to the skilled nursing facility that's going to reduce their readmission rate and keep them 15 days instead of 30 days? That's the obvious choice for the patient. They can go home where they will have a non-inferior outcome. There's a lot of literature with millions of data points that compare patients when they leave the hospital, whether they go to SNF or to home. This is with, again, millions of data points. And if you look at the things that we care about, like readmission, mortality, functional status improvement, when
hospital-acquired conditions.
Hospital-acquired conditions, absolutely. When like patients within these large data groups are compared, home is non-inferior to skilled nursing facility, but at a significantly reduced cost. So it's not where should my patient receive the care that he or she needs. It's what care do they need and where can we deliver that at the best possible price.
Reuben, I think you gave a great example on stroke. We keep talking about getting the patient home, and that's the most cost-effective and value-based care. A patient has a stroke, they need to go to a rehab center.
Absolutely.
But you approach it from the right direction.
Absolutely. So if you're a 50-year-old person, you come with a stroke, you should actually not go home. You need to go to a skilled nursing facility or an inpatient rehabilitation facility, depending on what your needs are and what you can do as far as your own rehabilitation. In a value-based world, though, we're being compared against a financial threshold. But if everybody's going to go to rehab appropriately, the only way to do well against that threshold is to properly capture severity and risk, because that extends the threshold and allows the providers in the hospital system to do well by that patient and by themselves.
Yeah, so we're accurately capturing what the patient is challenged with, getting them to the appropriate setting. And again, that is value-based healthcare. That is what we're doing. We're getting them the highest level of quality care at the most cost-effective rate, regardless of where they're at. This is the right place for them at the right time, getting the right level of care.
Absolutely. It's the right care at the right time in the right location, and going forward with the right provider. Is it a physician? Is it an advanced practitioner? And so that way we do what our patient needs, but then we do so in the most cost-effective manner. And I think this is the decision we make for almost everything in our lives. Actually, when my Cuisinart coffee maker died a year ago, I got on Amazon and I looked it up, and the newer model, it looked cooler, did a couple more things, but it was $150. The same model I had looked the same, did the same, but it met all of my needs, and it was $100. So I Amazoned the one I had already because I met my needs, and I saved $50. That is healthcare.
Absolutely.
Fantastic. Well, thank you, Blain. Thank you, Dr. Tovar. This has been a really great conversation. I'd love to now turn it over to the audience to address some of their question and answers that they submitted. So just a reminder for our audience, you can submit any questions you have by typing them into the Q&A chat box on your webinar console. And we'll go ahead and get started with the first question. So this audience member says, hello, I've been a practicing hospitalist for 17 years. Why should I change something that's been working for me so far?
Well, I think the main thing is seeing 25 to 30 patients really is not sustainable over a long time. I think we all, as physicians and advanced practitioners, want to work in a system where we are worried about our patients' quality of care, not necessarily how many contacts I have in a day. It is a much better feel when I leave the hospital to know that I have worked in a way that reduced hospital-acquired conditions, that has reduced use of skilled nursing facilities and other institutions, and I've improved cost containment for my patients. So I think it's just a completely different approach. And if the physician is worried about the financial impact, well, the incentives for quality performance can equal, or if not really be greater than the volume benefits.
Fantastic. Thank you for addressing that one. And then our next audience question is here. This attendee wants to know, how does having this data as a CEO change your day-to-day operational outlook?
Absolutely. I'd love to jump on this one because I've already talked about, for a greater part, hospitals do require and operate on legend and lore. I love to give the example of, delays in length of stay and sitting down with my case management team and trying to understand as a hospital CEO, what is delaying this? Well, this specialist is not doing their reads. and you need to fix this. And you march down to the reading room and sit down and say, Dr. X, why are you not doing, Dr. Tovar, why are you not doing your reads? And you're adding length of stay. Inevitably, Dr. Tovar would look at the screen and go, I'm reading this, and this test was done this morning. What do you mean there's a delay? Conversation's over. Whereas now you've got this type of real data at your fingertips, real information at your fingertips, that I can go down and sit down with the group of specialists and say, I need you to look at this. I need you to look at what delays you're causing. And here are the 5 patients in the last 2 weeks that have added 15 days to the length of stay at the hospital as a result of your inability to go down and do that read in a timely manner, or come in on Sunday and do reads, and patients are just sitting over the weekend. I've moved from a subjective conversation to an objective conversation, and it's much more higher yield. It completely changed my ability as a CEO to identify efficiencies and breakdowns in the hospital in one way, because the hospitalists are capturing in real time avoidable days in the institution. So I know as a CEO where I've got a breakdown in my radiology department, I've got a breakdown in my lab, I've got a breakdown in therapy, I'm not mobilizing patients and it's getting documented, or I've got a breakdown with the local skilled nursing home that won't take patients anytime Thursday after 8 o'clock in the evening. And I've got real data that I can sit down and have honest conversations and solve problems together to get the patients the care they need in a timely manner.
Wonderful. Thank you, Blain. And this next attendee wants to know, or they're saying, the lack of the data I have at my fingertips currently is driving me insane. I'd love to implement a tool like the one you described, but I've been burned by long and dragged out integration and implementation processes. So from your experience, how long does it usually take to get the hospital and physicians on board and just to have everything running smoothly?
I'll start in, and then I'm going to toss over to Reuben too, because he gets involved in all of our implementations. First and foremost, data transfer is easy. It's an HL7 interface. It comes across the IT team, very little work on that aspect. And then it takes just a few days for a provider to actually capture and see what it takes to start documenting and capturing. Even prior to, initiating, we can take a data set dump from a hospital and, take key criteria, and then move it into our organization and move it into our database and push out initial reports to establish baselines. But for providers to then have this information at their fingertips, Reuben, you see it all the time when we implement. It doesn't take much time at all.
Using the tool it takes, they'll be expert in 5 to 7 days. I've been using the tool for a decade, and I would say I became expert level within a week. What's integral though is that the tool is giving so much data that the physicians understand the data and know how to interpret that data so that they can self-manage. And so part of our implementation and part of the startup is not only the electronic connection, but it's also ensuring that our physicians understand clinical documentation integrity, value-based purchasing, MIPS, MACRA, bundled care, the dynamics of an accountable care organization or other managed Medicare product. And so that when they know value-based care and the business of healthcare and they receive data, then they can interpret the data themselves and they can self-manage. And then that's the winner.
Well, being an expert in a week sounds fantastic. So thanks for addressing that point. This next attendee wants to know, how are you choosing next site of care to ensure you're doing what's best for the patient while also mitigating risk?
That's a great question. Again, I can't tell you how many times, sitting down with providers and the belief was, well, send everybody to skilled or send everybody to a post-acute setting because that's what provides safer care. It does for patients, but there are also a number of patients that the right setting is to send them home or to capture it. And if you've got the information, again, I'll go from you start capturing the data on what diagnoses are going to what next site of care, simultaneously as you've got the data coming to you from these next sites of care, whatever that post-acute setting would be, we aggregate that, put it into, real-time actionable information and sit down with the providers and show them, here is the readmission rate. Here are the hospital-acquired conditions. And it goes all the way back to closing that loop that Reuben talked about on informed decision-making based on actual performance. So when you're capturing next site of care location, capturing readmissions, capturing hospital-acquired conditions, you're able to then sit down and show the provider, and the provider actually knows of the 10 choices, this is the one that's actually going to perform better for your diagnosis. And patients get higher quality care and quality costs less.
Oh, absolutely. And I'll say, when they have to go to a skilled nursing facility, I think the star rating that Medicare gives a facility, a SNF, is good, and it tells you some information. However, what it doesn't tell you is mortality, readmission, and functional status improvement. There have been, again, with millions of data points, a comparison of 1-star, 2-star, 3, 4, 5-star facilities with respect to those indicators that we all care about. And the reality is there was no delta. So I'm sure the 5-star facilities are nicer, have a better, paint and TV and food. However, for the things that we're talking about, the items that drive value like readmission, readmission, mortality, and functional status improvement, they perform about equally. And the reality is much of that level of care can be met in the home setting, which is also shown with millions of data points. So then what indicator in my mind should you use to choose a SNF? To me, the ideal proxy for quality is the readmission rate. If I discharge a patient on day 5 with a severe illness to a skilled nursing facility, and that patient is there for 14 days, and then goes home and stays out of the hospital for 90 days, I think fundamentally we have done something correctly. However, if they leave that skilled nursing facility and return to the hospital in 7 days, fundamentally we have done something wrong. So I think it's that readmission rate that really serves as an equalizing proxy across the star rating.
Absolutely. Thank you, Reuben.
Thank you very much. And it looks like we have time just for one more question here before we turn to closing thoughts. To our audience, please feel free to continue to submit questions. If we don't get to it today, we'll be sure to follow up and get you an answer. But this last question is, what have you done to improve the chances of your patients going home instead of to a second institution?
From the physician perspective, there are certain things we get taught in medical school and residency, and we do over and over when we admit a patient. Some very, innocuous appearing orders really have a negative ramification on our patients. It's so often for an emergency room physician or an admitting nocturnal hospitalist to write clear liquid diet or NPO, meaning no food, or there's an order for a very restrictive diet for an 80-year-old gentleman. I don't think any 80-year-old man wants a severely restricted diet. I'm a 54-year-old and I don't follow a restricted diet. And so the diet choice and maintenance of their proper nutrition, and then the order of bed rest. We're afraid our patient's going to fall and break their hip. The reality, though, is if we maintain that bed rest through day 1, day 2, and then we finally notice it on day 3, I have created for that patient the syndrome of hospital-acquired disability. He or she came to the hospital ambulatory, and now they're not because of my bed rest order and my nutritional order. So what we do is provide the diet the patient will eat. We have them out of bed. We have them involved in their activities of daily living, and we involve the family in the care of the patient, because when that patient goes home, they're going to be with their family. Someone's going to come over and help them. So we have them understand what the needs of the patient are.
And I think the provider driving that is the key. The provider driving that discussion with the family. I mean, because that then couples back into a hospital's HCAP scores. If you've got a provider that is engaging the family in those type discussions and is insisting in driving the mobility, also, that is going to then compound into, what happens on the HCAP score overall. Yeah, I met with my provider. Yes, they answered my questions. Yes, they were attentive to my needs. It's key.
Wonderful. Thank you both for engaging our audience that way. As a reminder to our audience, please feel free to continue to submit questions if you have any more, but we are going to close things out here. But before we do, I want to let Dr. Tovar and Blain both give their closing remarks you'd like to leave our audience with. So Dr. Tovar, I'll let you go first. Sure.
I think access to actionable, trusted, validated data changes physician behavior. It creates an alignment of incentives for physicians with the health system so that value-based care can occur. And of course, the patient's the winner.
I think Reuben hit it perfectly. I mean, we've got to move to actionable information and have those conversations. Quality costs less. And when you get down to it, you're moving from subjective to objective data. When you look at objective data, again, I've talked about, the basic principle when you think about value-based care starting in 1982 with the DRG, it's the geometric mean length of stay. That is the target. And if we give that information to the providers and they understand, where that is, those savings to hospitals are extraordinary. You're going to see, and there'll be a link sent out to our geometric mean length of stay calculator and our savings calculator that you'll be able to put your information in and show you what we accomplish and what we will be able to save when we're focused on that. And your providers have the information they need to hit those targets and improve overall quality of care.
Wonderful. Blain, Dr. Tovar, thank you so much for the time today.
Thank you.
Thank you very much.
I also want to take a moment to thank our webinar sponsor, HNI Healthcare. To our audience members, if you want to learn more about the content presented today, please take a moment to check out our resources section on the webinar console. And also please take a moment to fill out our post-webinar survey. You can also keep an eye out for a link from us for the length of stay savings calculator. And we'll be sending that to you shortly. So thank you everyone so much for joining us today. And we hope you have a wonderful afternoon.
Thank you.
Thank you.